today we're going to be discussing the World Cancer Report webinar series. The World Cancer Report is published every 5 years and is designed to give a status quo of the research community in cancer research across the world, with emphasis on cancer research for cancer prevention. In between those formal reports, the World Cancer Report webinar series is designed to give you updates on particular subjects. For example, the recent one was on body mass index. Today, we're going to give you a discussion about germline genetics. The last 10 to 15 years have been a very exciting period in germline genetics and our understanding of the alleles that are involved in genetic susceptibility to cancers, and also more widely, many other diseases. This research has really come to the fore, and we're now really seeing great advances in the concept of a polygenic risk score, which is what we're going to discuss today, and particularly its application in cancer prevention. As Dominic said, I'm the chair today. My name's James. I've been working in germline genetics for almost 20 years now. And we're also joined by two great speakers, Nilanjalan and Linda Chituri. Both of those will be giving 20-minute talks, and then we'll have a follow-up with some question and answers. Throughout the period, please do post your question and answers in the question and answer function within the Zoom line, and we'll do our best to answer those at the end of the period. In terms of just the introduction, what I thought I'd do is give two slides which I've been using in my presentations throughout my career. This first one gives an indication of the heritability of various forms of cancers. In this instance, heritability is looked at by looking at family history in first-degree relatives of that same type of cancer. And what we can see is across a large number of different cancer types, we see an elevated risk in these individuals, which really does imply that there is some kind of germline susceptibility involved. For example, we can see breast, prostate, colorectal cancers, the common cancers, lung cancers. We see almost a twofold increase in the number of cancers in these individuals when they have a family history. We also see rarer subtypes, and sometimes these risks can be quite marked. For example, Hodgkin's lymphoma, and also testicular cancer, which can also be found almost 8-fold higher in these individuals, and also other types of cancers such as thyroid cancers and lip cancers. There are other ways of measuring these heritabilities. For example, we can use genetic profiles, we can also use twin studies, and all those different methods that estimate heritability seem to indicate the same thing, that there is definitely an aspect of germline susceptibility for a large number of these cancers. The last 10 years have seen an explosion in genetic studies, for example, genome-wide association studies and more recently sequencing studies, but also the older studies into families. And the net effect of these studies is that we now understand germline susceptibility better than we've ever done before. I recently looked at the European Bioinformatics Institute GWAS catalogue, which catalogues the number of susceptibility variants that are found across populations, and that now totals almost over 3,000 individual variants that have been linked to various forms of different cancers. And that brings me to my second introductory slide, which is this one. Now, this is just a really descriptive slide that plots the risk conferred by a genetic susceptibility allele as a function of its frequency in the population. Now, across this, we can see that there are certain alleles that are very rare in the population and tend to also have a very important effect on the gene product. And they confer, if we look at this axis on the x-axis, a very marked increased risk of developing a particular cancer. But thankfully, they are very rare in the overall population. There's a second category in the green. The rare alleles are really typified by BRCA1 and BRCA2. These are the breast cancer susceptibility alleles that are really well described and well known in the community, and confer a really important increase in risk in breast cancer, but other forms of cancer as well. There's a second category, which we call intermediate susceptibility variants, and these are typified by genes like ATM and CHEK2. They're still relatively rare in the population, perhaps 0.5% of the population. So if we have 500 people on the webcast today, maybe there'll be one or two of us that carry these susceptibility alleles. But nonetheless, they still have a relatively important increase in cancer susceptibility. The third category, which is on the right here, is more the common genetic variants. So these types of genetic variants are very frequent in the population. If we look at the people across this webinar, you'd find that most of us carry these susceptibility alleles, but they only confer a very small amount of genetic risk. The other thing we can do is if we could actually superimpose functionality across this bottom axis here, we'd also note that the degree of impact on the gene product tends to be much more minor on this axis compared to the very rare ones, which tend to have a much more important impact on the gene product. But the important nuance with these particular susceptibility alleles, the common genetic variants, is that there is in their number. They now number in the thousands. So what we can actually start to do is, while each individual susceptibility allele only has a very small effect, we can start to sum them together. So while each individual one is not necessarily informative, we can then combine them into a polygenic risk score, which sums these alleles together. And that's going to be the major focus of what we do today, we're going to discuss today. And why this is interesting is that now that we're understanding and discovering a large number of these susceptibility alleles, the individuals that have a large amount of these susceptibility alleles start to approach genetic risks that start to approach this, the risks associated with the very important BRCA1 and BRCA2 susceptibility alleles. And that type of thing, so by using the combination of these susceptibility alleles, we can start to identify at-risk individuals and take appropriate steps along those lines. And that's really what we're going to discuss today, how we use these genetic risks in the context of cancer risk cancer prevention. So with that, I'd like to introduce the two speakers today. Firstly, Nilanjan Chatterjee. Nilanjan is somebody I've looked towards in the context of germline susceptibilities for a number of years, following his work first at the National Cancer Institute and now in Johns Hopkins in Boston. Nilanjan's work is a statistical geneticist, so he's very much involved in methods development, which is a really important field, but he's also involved in the application of these methods, not only germline susceptibility, but also environmental factors. I personally am really looking forward to Nilanjan's talk, where he's going to discuss the impact of breast cancer on polygenic risk scores, and I also would like to take the opportunity to thank him again for participating in this webinar series. And I would like to pass the floor over to you, Nilanjan.
Thank you, James, for the introduction, and good day, everybody. I'm going to talk about today use of polygenic risk scores for improving stratified cancer prevention effort. And I want to first start by thanking all of my trainee and a very large number of collaborators from all over the world who have contributed to this research with me. Throughout this talk, I'm going to use breast cancer as a model to show how genetic risk score might be useful for risk stratification and aid cancer prevention. And as James mentioned, that for those of you who have been involved in breast cancer research, you know that breast cancer has been long associated with major genes such as BRCA1 and BRCA2, which are known to contain these mutations, which are very rare in the population, but the individuals who carry the mutation, they have a high risk. And then since about 2007, the genomoid association studies started arriving, and the sample size continued to grow in thousands to tens of thousands to more than 100,000. And now they are leading to discovery of this common variant, which individually only contribute to a small amount of risk, but in combination, because now we already have almost 200 independent genetic variants for breast cancer alone, in combination, they can start explaining a substantial amount of risk for breast cancer in the population. So keeping that context in mind, so we might think about how now we can define a polygenic risk score. And some people use the word terminology polygenic score or genetic risk score. They are all the same thing. So a polygenic risk score for an individual can be defined typically as the weighted sum of the number of risk alleles an individual carries for these different genetic variants, which in this case is the SNPs. And we will talk about in a moment, how do we decide how many SNPs to include? How do we decide what are the weights going to be? But once those are being given to you, you can calculate this score for any individuals in the population or your research study. And so you can think about this as a kind of a continuous measurement, like a biomarker measurement. Now, there are potentially number of different utilities for this kind of genetic risk scores. The one that I will focus today on my talk is the utility of it for risk stratification of cancers, in particular breast cancer, and how that might aid certain type of targeted intervention efforts. But there are other utilities, such as this can be used to improve the diagnostic utility of biomarkers such as the PSA, and that's what you're going to hear in the next talk from Linda. And this could also be a very useful research tool to understand links between various types of biomarkers, such as proteomics or metabolomics, and risk of cancers. Now, before you use genetic risk scores for any of these purposes, it is little bit useful to understand how are these genetic risk scores are being derived from these genome-wide association studies. So in a simple way, you can think that what genome-wide association studies provide you is that for each individual SNPs in the study, a p-value for its association with the risk of that cancer that you are interested in. And there could be some hundreds of thousands of these SNPs or even millions of them. And one of the things you have to keep track of them, and then we might sort those SNPs according to their strength of association, strongest in the top, like that means the lowest p-value, to the weakest association, that means the largest p-value. And at the same time, we keep track of how these SNPs are correlated with each other, because we know within the same region, the genetic variants might be in LD. And so we do not want to carry the same signal multiple times in the genetic risk score. Now, if this is your data, the way you might develop the first simplest genetic risk score might be to focus on SNPs which has reached a very high level of significance, say typically the genome-wide significance level, p-value 5 times 10 to the power minus 8. And among them, you choose your independent SNPs, and then you can estimate their effect sizes from that genome-wide association study itself. And then this is your polygenic risk score, as I defined earlier. And this can be then now evaluated for in the studies outside that original genome-wide association studies, if you have the genetic data on the individuals. A more complicated genetic risk score would be to include more variants by relaxing that threshold for significance, and then include independent SNPs in that, the additional independent SNPs. And in fact, we can vary that threshold. And if I have an independent study, we can see that which threshold gives me the best performance of that genetic risk score in that independent sample, independent of that original GWAS. And so this is popularly known as a clumping and thresholding method. And then you have even more complex method, which can potentially incorporate all of the SNPs in your genome, like hundreds of thousands or millions, based on this Bayesian and machine learning method, which can automatically account for linkage disequilibrium. You do not have to choose independent SNPs. It can perform SNP selection, as well as estimation and provide robust estimates of those coefficients. So you can see there is a kind of a variety of different methods which can produce more and more complex genetic risk scores. And so let us see how this has been applied to breast cancer research. So the genetic risk score for breast cancer has been developed so far from the Breast Cancer Association Consortium study, which is centered in Cambridge. They originally had developed a genetic risk score based on 77 independent SNPs based on a genome or older genome-wide association studies, which are about 60,000 cases and controls. And that genetic risk score showed an association about 1.5 odds ratio per standard deviation unit increase in the value of that score. And this corresponds to an area under the curve value of 60.3%. As you may know, some of you may know, this is a measure of discriminatory performance of the model, or in this particular, the genetic score. And then more recently, based on a much larger genome-wide association studies, and this particular p-value threshold of 10 to the power minus 5, they defined a genetic risk score based on 313 SNPs, which shows a markedly increased association compared to the original score. You can see in terms of both the odds ratio as well as the area under the curve values. And finally, in the same data set, they also applied this machine learning algorithm called LASSO, and that resulted in a genetic risk score that includes 4,000 SNPs. But that also led to an improvement, but you can see that there's a small improvement compared to that a more parsimonious genetic risk score. So for the rest of the talk, I'm going to focus on the breast cancer polygenic risk score defined by these 313 SNPs. One thing I would like you to notice is that this area under the curve value, those who are familiar with what it measures, is kind of modest because the minimum value it can have is 50%, and the maximum value it can have, which means perfect discrimination, is 100%. So that has led to some debate that whether such modest discriminatory performance of these genetic scores can actually lead to any useful public health applications and clinical application. And I will try to show later in my talk that in spite of this modest discriminatory performance, which means that the genetic scores may not be highly accurate for prediction at the individual level, but they can still make a meaningful population level impact for developing stratified cancer prevention efforts. Now, so far that was for breast cancer, but analogous efforts are going on across many, many cancers. So this is the information I gathered from this catalog called PGS catalog, which provides information on genetic scores and how to build this genetic risk score. So you can see across these cancers, I have collected the information on the best genetic score available, and you can see different genetic scores contains different number of variants, and this shows the odds ratio of association. And you can see that generally that for cancers which we have largest genome-wide association studies like prostate cancer or breast cancer, they tend to have the most predictive genetic risk score. But there is actually exceptions to this trend, which is like, for example, if you look at testicular cancer or even thyroid cancer, you will observe that even with a small genome-wide association studies has led to a number of findings where these SNPs have relatively larger effects, and they are leading to genetic risk scores which are fairly predictive of those cancers. And the good news is that there is still opportunity to grow this polygenic risk score in terms of their predictive performance by increasing the sample size of the genome-wide association studies further. So here I'm highlighting 3 different cancers: testicular, oropharyngeal, and breast cancer. And I'm showing that the x-axis, if I increase the sample size, and these are in thousands, so 250 means 250,000 individual. And if I increase the sample size, how the performance of the genetic score in terms of the measure AUC will improve. That is shown on the y-axis. And that horizontal dashed line shows what is the limit suggested by heritability, and that is the maximum we can achieve ever based on these common variant genetic risk scores. And this blue dot on this curve shows that where we are currently are. So you can see that although depending on different cancers, we might be somewhat closer to the limit or really off the limit. We have a long way to go, but across cancer, there is still plenty of opportunity to improve these genetic scores by doing even larger studies. Now, if you want to take these genetic risk scores for clinical application, one really important thing is to consider that how do we combine these genetic scores with other types of risk factors. For example, in the breast cancer, the hormonal and lifestyle factors, family history, these are pretty easy to collect, and they're already incorporated in a number of standard risk factors, standard of risk models. And there are also other factors like breast density, which is harder to collect, but potentially can help to the risk models. So to do that, we have been developing absolute risk model, which helps you to bring together all the information for a cancer or some other disease, including the disease incidence rate or the cancer incidence rate in the particular population, particular country, particular racial or ancestry groups. Also, the different risk factors for the cancers and the distribution of those risk factors in the population, and also any available intervention and the corresponding clinical guideline, which tend to be based on absolute risk thresholds. And also, I think it's really important if we are trying to show how these models might perform across different countries or different ancestry and racial groups within a country, then it is really important to do it based on absolute risk models, because we know that these groups are actually quite heterogeneous in terms of the incidence rate of cancers, as well as the underlying risk factors and their distributions. So to do this, we have been developing this framework called ICARE, standing for Individualized Coherent Absolute Risk Estimator. This allows any user to develop an absolute risk model for any cancer or any disease, provided they can collect data on certain types of inputs, including starting with the relative risk parameters associated with the set of covariates or risk factors they want to include in the model, a data set that can characterize the risk factor distribution of the risk factors in the population, incidence rate of the cancers in the corresponding population, and potentially mortality rates from competing causes other than the disease you are interested in if you want to adjust your absolute risk for those factors. And there is related software for this so that people can easily use it. And based on this framework, we developed two different models. One we call a literature-based model, where we got the relative risk information from literature survey. And there are two versions of this model for women younger than 50 and older than 50. And there's another model we developed based on internal analysis of data from cohort studies from the NCI cohort consortium studies. But this model was only available for women greater than 50-year-old. And then we did perform an extensive validation study of these models in independent cohort studies, and we are satisfied. But today I'm going to focus on how these models shows, like in terms of projections of risk in the population, and show the value of how this genetic risk score add value to this risk stratification concept. So what we did is I took those model, one of the model, which is the literature-based model for women older than 50. And based on this model, we projected 5-year absolute risk for US non-Hispanic white women in the age range 50 to 70-year-old range, taking into account age distribution available from US Census data and risk factor distribution available from health survey data. And what I'm showing the distribution of 5-year absolute risk according to 3 different models. One is based on standard risk factors, which includes only a handful of risk factors. The genetic scores are a combined model which combines both the standard risk factors and the genetic score. And the focus is here that 3% absolute risk threshold, which is currently being used by the US Preventive Service Task Force for recommending for women to take the risk-lowering drugs such as tamoxifen. And because this is a pretty high risk threshold, and this is not something you want to apply to you want to recommend to the whole population. You want to give it to the only pretty women who have pretty high risk. So you might ask the following question, then according to these 3 models, if we apply, how many women in the US we are going to identify in this group will identify at that risk threshold? And you see that if we just use the standard risk factor model, we'll identify about 3.4 million people. If we use the extended model, that will identify 2 million additional women who falls into this high risk category. And then based on this model, we can further estimate in this high risk category, how many additional cases for that potentially future cases we are capturing. And you can see compared to the classical model, which only includes risk factors, no genetic risk score, the combined model is going to capture 100,000 additional cases. And then you can do your calculation based on the effectiveness of the therapy, proportionally that many cases could be prevented. So you can see here that this genetic risk score, although this has a modest discriminatory performance, about 63%, you can see how it can be still useful for population risk stratification and to make a meaningful impact at the population level in terms of the number of disease prevented if it is used in combined with other risk factors to define high-risk groups. If you are using genetic risk score, for risk stratification, another important thing to keep in mind that these genetic risk scores are actually provides risk stratification even among individuals who carries these high-risk mutations, such as BRCA1 and 2 mutations. And in fact, because these women who have already high baseline risk, these polygenic risk scores can provide a very significant stratification of the absolute risk for these carriers. For example, in this figure, what I'm showing that the absolute risk over lifetime absolute risk for carriers and according to the percentiles of the genetic risk score, and you can see that the absolute risk can vary from about 20% to about 80% around that percentiles of across the 2 extremes of that genetic risk score distribution. However, one major limitation of this genetic risk score has been that they have been mainly developed from using genome association studies conducted in European ancestry populations. And as a result, when these genetic scores are taken to other populations, we see that they're not performing as well, which is not surprising. So in this study, for example, they evaluated how the genetic risk score defined by that 313 SNP for breast cancer performs in other non-European populations within America, like African, Latino, and Asian populations. And they found the risk stratification, if you look at how the risk increases or decreases according to the strata of the polygenic risk score, you will see that while we get a pretty good stratification at the tail end, for the risk for the European population, but those risks are now attenuated for the other populations. In particular, it is worse for the African population, where you see the most significant attenuation, which means that we need much larger studies in the future for non-European populations to improve the performance of the genetic scores for other populations. So with that, I'd like to come towards conclusion, and just to remind you some of the benefits and pros and cons. One is that we showed that how this can be helpful for risk stratification, and this could be evaluated early in life. Once the genetic data is collected, it can be applied to calculate genetic risk score across many diseases. But it has limitations in them because it has limited accuracy for individualized prediction, and it is now less predictive in non-European populations. And these genetic risk scores are only associated with the risk, but not so much with severity or progression. Thank you.
Thank you very much, Nilanjalan. Now I would like to introduce our second speaker. We will take questions, but only after the second speaker. Linda is somebody who has I've worked with for a number of years now. She did her PhD with Regine Hung in Canada, and has now moved to California, first working in the University of California, and has now just been recently appointed in Stanford University. We here at IAC know her well because as part of a PhD, she spent some time here working at the agency, particularly with my colleague Matthias Johansson and colleagues, and also produced a really interesting YouTube video describing some of the work she did with Matthias, particularly looking at genetic contributions versus environmental contributions. I believe that link is on the website, the World Cancer Report website. If you haven't seen it, do check it out because it's a really instructive video. Linda, thank you. I'd like to again extend my thanks for you to presenting today here at the webinar, and the floor is yours.
Thank you so much for that wonderful introduction. Thanks. So again, thank you, James, for the introduction, and I'm very excited to be with you all here today and share some recent work that I've been doing in the area of polygenic risk scores. So just a quick overview, as Nilanjan has previously mentioned, polygenic risk scores have a number of different applications, but really what we're most interested in is trying to use them for more personalized and accurate risk assessment. And the idea is that genetic information can help us better prioritize high-risk individuals for appropriate clinical interventions. Now, another potential application of polygenic risk scores that I will briefly touch on has to do with opportunities to get additional insight into etiology. So for instance, we can look at different cross-trait polygenic risk score associations and get a little bit more of an idea as to which susceptibility variants or regions are shared between different cancers or other traits. But for most of my talk today, I will be discussing some recent work on trying to use genetic risk scores to improve the accuracy of diagnostic biomarkers, and I will be focusing on prostate-specific antigen. So just to touch on this example of using PRS to get more insight into trait etiology, this is an example from a study that I was involved in where we are really interested in the shared genetic basis across different cancers. So here we developed cancer-specific polygenic risk scores for 16 different cancer types. And we looked at associations with other non-target cancers. So for example, as you can see in this Scrabble board style diagram, on the y-axis, we have the cancer, and across the diagonal, you can see the odds ratio for the PRS associated with the cancer for which it was developed for. And then all of the other values highlight significant associations for that polygenic risk score with another cancer. So for instance, we can see that there is a significant higher risk between the polygenic risk score for melanoma and oral and pharyngeal cancer types. And the colors here indicate obviously whether the association is increased or inverse. And so with this type of analysis, we identified 11 statistically significant cross-cancer signals. indicating that being at higher risk for one cancer confers a higher or potentially sometimes even lower risk for a different cancer. And to take this a little bit of a step further, we also looked at the associations between these cancer-specific genetic risk scores and a number of different putative risk factors or biomarkers. So I'm showing you part of a figure here that shows the associations between a particular cancer PRS, highlighted in different color, with a number of different traits. So for example, we see known risk factors such as cigarettes. We also see different lipids. And this, again, is giving us a little bit more insight into potentially some of the underlying mechanisms through which these polygenic risk scores could be influencing cancer risk. So now let's get into the main part of the presentation, polygenic risk scores for PSA. So I'd like to set the stage a little bit with an introduction to the clinical context for prostate cancer screening. So PSA is an enzyme that is produced by both normal and cancer cells within the prostate gland. This is an enzyme that is secreted by epithelial tissues. And the main gene that encodes the PSA enzyme is this KLK3 gene in chromosome 19. Now, it's really important to note that PSA is a relatively sensitive biomarker, but it's not very specific. So for example, PSA levels rise with older age, whenever there's the presence of inflammation or infection within the prostate, and also as a result of the condition that's called benign prostatic hyperplasia, which is simply prostate enlargement. So for that reason, guidelines around the world really discourage the use of population-based PSA screening. So although this biomarker is very commonly used, it is not formally recommended and is not formally implemented as part of population-based screening. And the reason for that is really this relatively high burden of false positives, relatively modest mortality benefits that PSA screening confers, and most of all, there's this concern with overtreatment of clinically insignificant disease. So what we really want to do is to really detect tumors that are likely to be more aggressive and life-threatening. And instead, it seems that this test really tends to pick up a lot more tumors that are of lower grade and really just result in overdiagnosis and potentially unnecessary treatment. So the hypothesis that we're working on here is, can we use genetics to improve the accuracy of PSA testing for prostate cancer detection? And I'm going to try to make the case that PSA is a biomarker that's really amenable to this approach for several reasons. So first of all, PSA levels are highly heritable, and they are also polygenic. So previous studies have identified over 40 genome-wide significant variants across the genome that are associated with PSA levels. And heritability studies indicate that common variant heritability is between 30 and 40%. And so what we would like to do is to personalize PSA screening by correcting someone's observed PSA value based on their genetic score profile. So another way of thinking about this is that we would like to account for the variation in PSA levels that is due to genetic factors. And we're sort of trying to remove that noise and then maximize the residual variance that is indicative of PSA elevation due to cancer. So in order to do this study, we conducted this multi-step analysis. So this is just an overview of the precision PSA study design. So the first thing we wanted to do is to conduct a GWAS in men without prostate cancer. This is very important because we're trying to capture the genetic determinants of constitutive PSA elevation. So this is why it's very important that we look at PSA levels in men who have not been diagnosed with prostate cancer. So we conducted a large multi-ancestry meta-analysis of over 95,000 men. As you can see in this figure, unfortunately, close to 90% of the sample is predominantly European ancestry, which will have implications for some of the results that I will discuss later. So the second step was to then use these GWAS findings to develop and validate a PSA genetic score. And we validated it in 2 independent cohorts. And then the last component is to see whether this genetic score can actually be useful with respect to 2 main clinical endpoints. So here we're interested in how does this affect eligibility for biopsy and risk prediction for prostate cancer overall. So this is just a quick overview of the main GWAS findings from the first part of the analysis. So this is the largest GWAS of PSA levels to date. And we identified 128 PSA-associated index variants. So these variants were selected using LD clumping. So we're effectively picking the strongest association signals within specific genomic regions. Here we use a pretty conservative threshold for selecting these independent signals. And as you can see in the zoomed in circular Manhattan plot, this GWAS really identified a large number of novel variants that were not previously detected. So this represents a substantial increase in the power compared to previous GWAS of PSA. So combining these 128 variants then into a polygenic score, the first thing that we wanted to do was really make sure that this is a robust predictor of PSA levels. And so we validated the genetic score in 2 cancer prevention trials. So here I'm showing you the results in the prostate cancer prevention trial PCPT study, where we can see the p-value for the trend for the association between the quantiles of the polygenic risk score on the x-axis compared to baseline log PSA levels on the y-axis. And then also looking at the same figure in the SELECT trial, this is another cancer prevention trial. We can see that in both of these trials, the polygenic risk score is really robustly associated with baseline PSA levels in cancer-free men. Now, it is important to keep in mind that because these are clinical trials, this is a highly selected population. So both of these trials specifically enrolled men with low PSA levels. Now, in addition to p-value associations, I think it's also important to look at effect sizes. So again, in the PCPT, here I'm visualizing the effect size for a standard deviation increase in the polygenic risk score. And we can look in the overall sample as well as stratified by age, because age obviously is a very important determinant of PSA levels. And again, we can see here that the polygenic risk score is associated across all age groups, although as expected, the effect size drops a little bit in the older categories. And again, we see the same pattern in SELECT, so it is reassuring that we see very consistent results in these 2 independent validation cohorts. However, as I previously mentioned, one limitation of the study is that it is predominantly comprised of participants of European ancestry. And so when we look at the proportion of variation that is explained by the polygenic risk score in other ancestry groups, we can see that while it performs pretty well in men of European ancestry, it explains between 7 and 8% of variance in PSA levels. When we look at predominantly African ancestry populations, admixed groups, and East Asian participants, the proportion of variation explained drops substantially. So that is certainly a limitation. So now that we've established that our polygenic risk score is a reasonably robust predictor of baseline PSA levels, we can now move on to the next step of then trying to use this information to genetically correct PSA levels. So what I'm showing here in this diagram, excuse me, is this idea that what we want to do is derive a personalized adjustment factor for each individual. So effectively, what we'd like to do here is normalize someone's PSA level based on their polygenic risk score distribution. So what I'm showing here is that we derive this very simple normalization factor, which really scales someone's polygenic risk score value relative to a population mean. Now, the population mean is always calculated in controls, and it can be calculated in the target study or potentially obtained from an appropriate reference population. Having calculated this adjustment factor, what we simply do is take someone's observed PSA value and divide it by this factor. My apologies. So now let's take a look at what these genetically adjusted PSA levels actually look like. So again, here we're looking in our 2 validation cohorts in PCPT and in SELECT. And The box plots outlined in pink show the genetically corrected PSA values. And as you can see, there is actually a substantial difference, particularly in the number of men who end up having genetically corrected PSA values that are actually quite higher than their observed values. This is particularly interesting because both of these trials enrolled men with low PSA, but at least not higher than 40 nanograms per milliliter. And we can see that after applying this genetic correction, the number of men with PSA above that threshold actually increases. And this is an important threshold because PSA of this level is commonly used for further diagnostic testing. So now let's take a look at some clinical applications of genetically adjusted PSA. The first question we're interested in is, how does PSA adjustment affect biopsy referral decisions? So here we're looking at a real-life data example from the Kaiser Permanente health system. So what we've done here is we obtained PSA measurements on a number of prostate cancer cases, and what we're looking at here in this flow diagram is we start with their PSA value before their prostate cancer biopsy. We then apply the genetic correction, and then we look at how their PSA values change after this genetic correction in this next column. And then ultimately, we evaluate reclassification at age-specific thresholds that are used in Kaiser Permanente to recommend whether somebody receives a biopsy or not. So basically, we're trying to see what would have happened to these men had their clinician looked at their genetically adjusted PSA levels instead of their directly measured PSA levels. And in particular, we're also stratifying by Gleason score. Gleason score is one of the most important indicators of disease severity in prostate cancer. So men with a Gleason score below 7 are typically considered to have more indolent disease. So a really interesting observation here is that, first of all, we're noticing that using genetically corrected PSA values would actually result in approximately 13% of these prostate cancer patients becoming ineligible for biopsy. So this is also an indicator that most of the men in this biopsy ineligible category are also those who have relatively indolent disease. So I think this really speaks to the potential of using genetically corrected PSA to potentially reduce overdiagnosis of disease that is clinically insignificant. Now, obviously, these are prostate cancer cases, and so the fact that so few of them actually become eligible for a biopsy can look a little bit concerning. But we also have to keep in mind that there's limited opportunity here for upward classification, because in order to have had a biopsy, they would have already had to meet specific criteria. And now moving to a really unique population. So we had a number of men within this cohort who were actually controls, but did undergo a prostate cancer biopsy. These were effectively men who have had a negative biopsy. And again, looking at reclassification at these thresholds, we can see that approximately 20% of these men would have been able to avoid this biopsy had we looked at their genetically corrected PSA levels instead of directly measured PSA. Now, there's a little bit of a caveat to this particular analysis because this particular subset of controls from the JERA cohort were actually part of the discovery GWAS. So there's a little bit of an in-sample bias. So we could be potentially overestimating the impact of the genetic correction. But nevertheless, it is really encouraging to see how genetically correcting PSA levels results in meaningful reclassification at a clinically relevant endpoint. And now finally, moving on from looking at biopsy eligibility, what's really important, of course, is risk prediction. And in particular, we're very interested in aggressive prostate cancer because prognosis for aggressive prostate cancer is actually much, much worse than for prostate cancer overall. So generally, prostate cancer survival is well over 90%. But if you look at men who are diagnosed with aggressive disease, defined using these criteria or similar combination of factors, survival really drops to anywhere between 30 to 40%. So this is really a patient subgroup that we're most interested in. And so what I'm showing you here are results from the PCPT trial, where we compare the classification performance of a number of different models. So the first thing that we look at is whether the polygenic risk score for PSA itself is associated with prostate cancer. And it's very encouraging to see that this is not the case, because of course, the genetic score is designed to capture PSA variation in cancer-free men. Next, we'll look at the performance of a recently developed polygenic risk score for prostate cancer from this paper that was published about a year ago. And we can see that both directly observed PSA and genetically corrected PSA actually perform better than just using the prostate cancer genetic score. And then finally, comparing genetically corrected PSA in the light blue, we do see that it is more strongly associated with aggressive disease than directly observed PSA. But the best overall model is really achieved by this combination of the prostate cancer genetic score and genetically corrected PSA. So these are two different predictors that are giving us orthogonal information, and it actually is quite encouraging that we're able to achieve an out-of-sample AAC of above 73% in this data set. Now looking at this exact same type of analysis in SELECT, again, we see that genetically corrected PSA performs better than the polygenic risk score for prostate cancer alone, and then combining these two types of predictors helps us achieve a pretty high AUC, getting close to 80%, specifically for aggressive prostate cancer. And so with that, I'd like to just quickly summarize our findings. So what I've presented here today is a novel application of polygenic risk scores, specifically for personalizing diagnostic biomarkers. So this is a little bit different than a typical application, because we're not so much trying to directly predict PSA levels genetically and then integrate that into clinical practice. But what we're really proposing is to use genetics to refine a biomarker that is already being used. We also have some preliminary data to show that this type of genetic correction has potential to reduce overdiagnosis and unnecessary testing, such as avoiding up to 20% of negative biopsies. And it also shows that it can improve detection of aggressive prostate cancer, which is really the type of prostate cancer that we're most concerned with in this setting. And I think, again, this type of application has a relatively straightforward path to clinical translation, because instead of, for instance, trying to develop different PSA thresholds for each person, which would probably be pretty challenging to implement clinically, we're actually simply just trying to adjust the accuracy of the biomarker and allowing clinicians to continue using the established thresholds for defining high-risk individuals. But of course, there are some challenges with this work and some important future directions. So as I've emphasized earlier, the performance of the genetic score in non-European ancestry populations is really substantially worse than it is in European ancestry populations. And there are currently efforts ongoing to have a much larger and more diverse GWAS of PSA levels, and hopefully develop a more multi-ancestry polygenic risk score. Also, the polygenic risk score that I presented here today is very simple, and it's based on genome-wide significant variance. There's a lot of opportunities to improve the performance of the score by using more sophisticated PRS modeling methods. And of course, it's really important to evaluate genetically adjusted PSA levels in a range of clinical settings. So I've presented findings from one real-world application within the Kaiser Permanente health system, but it is really important to test this in a number of different settings to really understand the cost-benefit trade-offs of applying this genetic correction. And the last point that I didn't touch on in this presentation, but is also an active area of work, is to really try to better understand and disentangle the genetic determinants of PSA elevation from genetic risk factors for prostate cancer, and to really try to use both of those pieces of information to maximize overall prediction of prostate cancer risk. And so with that, I would like to thank everyone who was involved in this study, as well as all the investigators who have contributed data. And I welcome your questions. Thank you.
Thank you, Linda. Excellent talk, and it's great to see that PSA stuff. That's really fascinating. We've had a number of questions on the chat, on the Q&A. So for the rest of the community, or those that you out there, please do send your questions through, and we'll try and now discuss them. We have formally only another 7 minutes, but I'm aware that both Nilanjan, myself, and Linda will be around afterwards, so we can stay on a little bit if you have other questions that may come up. Just from those that have come through from the moment, there's a couple of really good ones. Linda Nilanjan, one of the ones that I think is really interesting is looking at the notion of distinguishing between aggressive forms of cancer and less aggressive forms of cancer, and all the other attributes like stage and so forth. Do you think there's the polygenic risk scores are going to have an application of that, say we can grade patients once they're diagnosis and think about outcome? Any thoughts on that?
Linda, you want to go first? Linda is muted, but I'll try to answer a little bit, and then it'll be good to hear her thoughts. I think one challenge I see, there are a couple of challenges which I typed, is that it is sometimes hard to get very large genome-wide association studies on, with cases that are very well characterized outcome data, like, stage, grade, survival. And so that would be one challenge, to find this kind of risk scores that would be predictive of. We have already seen that we need large studies. And another question I have in mind is that, because we knew that for risk, we had good estimates of heritability. So we knew that there are genetic disease, there is a significant genetic component in that determines risk. But we do not have analogous heritability studies as much for cancer outcomes. So the question is that how much genetic component is there in determining outcome versus it is mostly based on treatment and other factors, that is also remains uncertain. So I think it's a little bit more challenging than developing the polygenic risk score for risk, but I think it's very important to do those studies and to figure that out.
I certainly agree with that. And I think the data part has been a big limitation in terms of collecting appropriately large data sets, and also considering the differences in cancer treatment and how that influences outcomes in different settings. So it's a little bit more challenging to harmonize. And potentially another challenge to consider is trying to understand disentangle again genetic predictors of disease incidence from outcome. That, because there's potential for bias there, and that can also influence our findings. But I certainly agree that it's very important.
So Linda, just to follow up, I mean, your work, you looked at aggressive prostate cancer, which is looking great. I mean, seeing AUCs of 0.8 is remarkable once you're starting to correct. It's really quite remarkable. How did it compare if you're looking at, say, other less aggressive for, say, lower Gleason grades and so forth? Is it a graded thing, or what did you see there?
We definitely see that the additional benefit of the genetic adjustment is much more for aggressive disease than for low-grade disease. And I think that's a little bit expected, because I think a lot of the genetic predictors, both for prostate cancer risk and other predictors, are really, I think, geared towards low-grade disease, because that is overwhelmingly the type of prostate cancer that is included in the GWAS. And again, I think this is often what happens, is that we're predicting PSA elevation, not necessarily always PSA elevation that is due to cancer. So yes, I would definitely say that. I don't remember the AUCs off the top of my head. I think it's a little bit lower than 80, but the relative, I think, importance and the added value of PSA genetic prediction, I think, is mostly seen for aggressive disease. And
I just noted that Deborah Thompson, hi Deborah, has just made a really quite interesting question. She was just wondering about what the PSA levels were trained on, including circumstances under which the PSA was measured.
That's a really great an important question. So in our discovery GWAS, we use data from several data sets. So the UK Biobank cohort was one contributing study, Jarrett cohort, another contributing study. Most of these studies were sort of population-based cohorts where PSA was measured as part of sort of routine clinical care. So they weren't really formal trials. We used formal trials to evaluate our polygenic risk score, but there again, we only used the baseline measures. And something else that I didn't really mention during my talk is that for our GWAS, we restricted PSA levels between had to be greater than 0 and below 10 nanograms per milliliter. So we want to look at a pretty large range of PSA variation, but try to stay below what is typically considered to be indicative of prostate cancer.
Another one for you, Linda. Matthias, my colleague here at IARC, has asked, he's made a great comment, beautiful example of PSA and prostate cancer risk. Can you discuss if it matters whether the risk factors you seek to genetically correct for is causal or not? Maybe not. Yes, and this no, I guess. Anyway, over to you.
I think that's a really great question. I think in this particular case, I think oftentimes with polygenic risk scores, we're not particularly concerned with causality. I think here it is something that we do have to think about, particularly for understanding the degree to which the prostate cancer polygenic risk score is really modeling prostate cancer risk and actual, carcinogenesis versus just PSA elevation. So we do have to get into that a little bit and try to disentangle which pathways are modeling what, because I think they really have to be separate and orthogonal. We want to use genetic determinants of benign PSA elevation to sort of correct PSA levels. And so we really want to keep that separate from specifically predicting prostate cancer risk.
So maybe switching over to Melangeline. Danielle from I think that's in the Netherlands, has made a couple of really interesting comments and more broader. His first question was regarding about heterogeneity of different ethnicities. I know this is a big issue and something that Melangeline has considered quite a lot. How much an impact? I know your slide you showed that there was quite an impact in breast cancer, but certainly for me is that someone works in some of the rarer types of cancers. How do you think we're going to be able to deal with the different populations and even within Europe? How well does it transport across Europe? But then what about continental differences? And do you think there's going to be an application?
Yeah, I think this is a major challenge for the field, that the fact that the GWAS has been mostly done in largely European ancestry populations, and we are seeing now that their performance is not as optimal in those other populations. So of course we need larger sample size and to improve the performance of those genetic scores. But there's also opportunity to use better methods, because we do have to remember that while there is heterogeneity in genetic risk across population, but there is also homogeneity. There are a lot of these common variants which are present in multiple populations. They actually have the same effect across populations. So that's why when you're trying to develop a genetic score for let's say one population like an African ancestry population or Latino admixture population, we should still be able to not only use data from that population, but we should also be able to use data from much larger European ancestry populations. And the question is that what are the best methods to do that? And that is still up the air. There are a lot of methods actually coming out to do that, exactly that. But there is a bigger question also that, especially I think I'm a little concerned about the kind of the difference we see between the, let's say, African ancestry population performance and the European population. Will we be able to ever kind of make them equal unless, with a kind of a little bit somewhat bigger sample size for the African ancestry populations and better methods? And I think the jury is out there. I mean, I think if it is the sample size requirement for those populations is as large as the European ancestry populations, then that's going to be very challenging because we are nowhere near that. We need really large scale studies like, Biobank in Africa and, kind of the effort we had in UK. And we are not there. So this is a concern. And I hope that we are in the situation where with the better methods and somewhat bigger GWAS on those populations, we can get much better genetic risk scores. But the jury is still out, like what would happen.
The second question is also about clinical practice. And this is a broad one. how ready do we think that the polygenic risk scores that we have are ready for prime time to be able to translate it into the clinic, and what would we recommend at the moment? This is quite a broad question, but yeah, your thoughts would be valuable. I mean, I personally, well, I value your thoughts.
I think it's exciting, like that this performance, we do see that, that especially for common cancer like breast, prostate, and colon cancer, you are seeing at the tail, risk at the tail is quite noticeable now, 4-fold, 5-fold, at the top 1% of those genetic score, or if you go to the 5%, is like 2-fold to 3-fold. So this is not something ignorable anymore. But I do think there is still barriers. One, of course, we talked a lot about they're not performing as well in non-European ancestry populations. So if we implement now, then that can create more health inequity than already exists, because we already have a lot of issues related to healthcare access, screening access by ancestry groups, and other factors. And there are other barriers also, like so like, for example, how do you communicate the risk? That is very important, and so that has the biggest impact in terms of intervention uptakes. And also we need to understand that cost effectiveness and who is going to pay for this, right? So that's something also important, that the healthcare providers are going to be excited about this, and so that, to show them broad utility. And I think like one of the things that people miss is that this genetic risk score, like once you collect the genetic data, it can be used to calculate genetic risk score across a vast number of traits and large number of cancers, large number of health outcomes. So we need to show also that how these scores can be useful not only for individual diseases and cancers, but also in terms of improving broader measures of health, like, for example, overall mortality or disability adjusted life years and things like that. So, and that kind of studies might be needed to convince the, like the insurance companies and healthcare providers that this is something useful to invest money, and that's going to help to better health and later, saving cost in terms of future treatments. But those needs to be still done.
And one comment I had was I saw a fascinating paper where they were looking about a very, very large genome-wide association study of height. It's in preprint at the moment. And I think the sample size was in the order of 2 million or 3 million. In your opinion, Langela, I know you looked at this. Do we need those types of sample sizes to fully explain the heritability for common genetic variants, or do you think we can be cleverer than that?
I think that was an interesting exercise to see how much you can push, but I think for cancers, we did some of the calculation. We do, like, for example, breast cancer, in a calculation suggests that we currently have about genome-wide association studies with almost 250,000 individual, 125,000 case and control. But if you can push that up to 500,000 cases and controls, at least for the European ancestry populations, then we will more or less be explaining 80% or 90% of that heritability. But I think, when you think about sample size, increasing sample size of GWAS, it's really important to consider now increasing sample size for those other populations. I think we'll have a better value in improving the prediction performance of this genetic score across populations if we now start investing more in the non-European ancestry populations. And we have to always remember that increasing sample size for any population actually helps other populations as well. So it's not that this helps in that population. And because especially in African population, they have so many unique genetic variants, and we have not studied them. And they can really, help not only the performance in the African population, but as well as other populations.
And the other thing, I mean, there's a nice question also from one of the attendees talking about cervical cancer and rarer cancers, and the idea of getting a couple of 100,000 cases of cervical cancer or kidney cancer or Hodgkin's lymphoma, it starts to become really, really problematic. And then the idea that we have to do that across populations as well. So I think we still need to be coming up with clever ways of translating the knowledge that we're learning from the different genome-wide association studies from cancer to cancer. And I really liked the cross-cancer analysis that Linda mentioned in that context, but also things like genetic annotations and so forth. So we can try and leverage the information that we've got from the large scans and try and translate them into the rarer scans and try and pull some interesting stuff out. I think that's really another important
Oh,
project.
I would also maybe add just briefly, just on the point of clinical utility. I think this is like today we both gave examples of cancers for which there are screening programs that are implemented. I think we also have to think about what about all the other cancers for which we don't have a formal screening or intervention program. So that is something else that I think limits clinical utility, where even if we could develop a well-performing polygenic risk score, what is then the relevant intervention? And yeah, I also noticed a question in the chat related to sort of licensing these different tests. And again, I think it is really important to only start deploying something when we feel like we can actually deploy a clinical product that will perform equally well in all groups. So that's a big challenge.
Another question that is chemo prevention. You touched on it a little bit, Melangela. Do you think there's a future there?
Can you repeat the question, please?
Chemo prevention. Could we be starting to target particular groups with particular profiles? And I know you mentioned tamoxifen slightly.
Right.
Do you think that that's a future?
Potentially, because I think that the chemo prevention is something, like that is not something will be recommended for, because of their, side effects. You will not be recommending them to population at large. And that's where you really need to identify high-risk women who will benefit the most. So it's about the risk-benefit calculations. And this is where I think we need predictive risk model but that is not only going to be based on genetic scores. We have to combine them with other factors and identify high-risk women. So I think there is a definite application. But for chemo prevention, I think one of the challenge has been that the uptake, that this, the current recommendation, because of their side effects and things like that, I've heard from other people that, the uptake is not that great. Now, whether communicating the risk that you are at a very high risk because of your genetics or other factor, is that going to increase the uptake? That's a very interesting question, right? And that's why I think like the risk communication is going to be very important. And, because you can provide the information, risk is a number, but unless we can communicate it in a proper way so that people have a good understanding about what that means and for individual's health, and then it may not have an impact on the people's behavior change. I think that's a very tricky topic, like how the risk or genetic risk can actually make better people follow good health recommendations. And I think there are studies which have showed that it doesn't, and there are studies which have showed that it does. And I think it's hard to make a general comment because it really depends on how the risk has been communicated, right? So I think we need more education, more studies of risk communication tools, and see how this can affect people's behavior in terms of screening or lifestyle changes or recommendation regarding medication.
Okay, I'm just looking through the different questions. Carl, hey Carl from Oxford, he's just put in an interesting question about using, this is probably towards Linda, looking at other biomarkers like the pancreatic biomarker CA125 and do you think we need to, are there other approaches, this demineralization of the biomarkers, the genetic corrections or whatever, do you think it's going to be applicable elsewhere and should be applicable elsewhere?
I mean, I certainly hope so. I think what we're seeing with PSA, I think my hope is that this could be an approach that we extend to other biomarkers. Of course, I do think PSA is a bit of a unique situation because it is highly heritable and really something that is so specific, so linked to prostate cancer. So I think finding other similarly strong biomarkers could be a challenge, but I think, Carl mentioned a great example here. CA125 for ovarian cancer, I think there's definitely potential to, if we have enough genetic signals to try to apply some type of similar genetic correction or adjustment to hopefully make those biomarkers more accurate.
Any other questions? I saw Vivian. Hi, Vivian. He's a statistician here working within the NME grant branch here at IARC. The question for Linda, I see you've half typed an answer, so would you like to type that one out?
I started typing it.
Hard to keep up, but this is true.
So I believe the question is about the potential for undiagnosed prostate cancer to sort of create some reverse causation in our PSA GWAS. I think, yeah, this is a really important point. It's something that we can't rule out conclusively. I think given the fact that we do have a pretty wide age distribution, particularly in UK Biobank, like we have PSA levels that were measured in men who are in their 40s, although they're, minority. But I think the combination with, trying to skew towards mid to slightly younger men and also using our maximum of 10 nanograms per milliliter cutoff, and also trying to use, registry information to really exclude prostate cancer cases, I think would probably lead me to believe that even if there are undiagnosed prostate cancers within our cohort, there will probably be a minority. So there is certainly some potential for that to influence our signals, but I would hope that it certainly wouldn't really create a lot of spurious signal. But yeah, it's a challenge for sure.
I don't see any other burning questions. I hope I have not missed anyone. I would like to again extend my thanks to both Linda and Melangeline for participating today. It's been such a wonderful session. Really heartened to see. I think we got up to around 230 odd people that are attending this webinar, which is really gratifying. I would also like to reach out to all of you for attending this webinar. It is, I personally find it such an interesting way to interact with all of you. And as we understand our lockdowns and COVID and the way the world has changed, these webinars are such a powerful tool, and it really keeps us connected in the community. So thank you all for participating in this particular session.